Welcome to my YouTube channel. Today we're going to talk about heparins. Kindly make sure you subscribe. It will cost you absolutely nothing. So the heparins are anticoagulants, and we're going to look at the classifications of anticoagulants before we look at the heparins. And anticoagulants, these are drugs that inhibit formation of a clot, or they interfere with the secondary hemostasis, that is the clotting process. So under the classification, we have indirect thrombin inhibitors, we have direct thrombin inhibitors, and then we have vitamin K antagonists, which inhibit vitamin K dependent clotting factors, which include factor 2, factor 7, factor 9, and factor 10, protein C and protein S. So indirect thrombin inhibitors, here is where we have the heparins, and then we have the unfractionated heparins, we have low molecular weight heparins, that is enoxaparin, and then we have synthetic pentasaccharide, that is fontaparinax. And then we have the new oral administered factor 10A inhibitors, that is the rivaroxaban, apixaban, and endoxaban. So the first three, these are IV medications or subcutaneous medications. These are drugs that are given using a syringe, whereas the new administered, obviously oral medications, they are oral medications. So the direct thrombin inhibitors include agabatran, lipiridine, bivaridine, and then daxibatran. So the first three of the medications, these are IV medications, whereas the last is the oral medication. Vitamin K antagonist, as I said before, this inhibits vitamin K dependent clotting factors, and they include warfarin. So let's quickly look at the heparins, and under the heparins we have low molecular weight heparins, and the examples include the parins. So anything that has parin is a low molecular weight heparin. That is enoxaparin, dalteparin, nadroparin, bemiparin, satroparin. And then the next thing is that the risk factors of heparins are less in low molecular weight heparin in comparison to unfractionated heparin. So it has a lesser risk of heparin-induced thrombocytopenia and osteoporosis. In addition to that, the reversal drug that we use, or other antidote that we use in terms of low molecular weight heparin and unfractionated heparin, because just let me tell you, unfractionated heparin is a larger molecule, and then now from it we get low molecular weight heparin. So they share similar characteristics, but sometimes they do differ. So in terms of the reversal, on board we usually use protamine sulfate, but in terms of low molecular weight heparin, it has limited antagonism. And then we usually monitor low molecular weight heparin using anti-XA, whereas in unfractionated we usually use APTT. And then it is usually excreted through the kidney. So a patient who comes in, you want to give them anticoagulant, but their creatine clearance is less than 30 ml per minute, then you'll prefer using unfractionated heparin because it is excreted by the liver. So unfractionated heparin, it has an increased risk of HTI in addition to osteoporosis, and then it has an increased reversal by protamine sulfate, and then it is monitored using APTT and is excreted in the liver. So in synthetic heparinoids, this somehow the way synthetic and low molecular weight heparins, they are similar in terms of their mode of action, and the mode of action of low molecular weight heparin and synthetic heparin is they stimulate antithrombin 3, which later inhibits factor 10A. Whereas in unfractionated heparin, it still stimulates antithrombin 3, but now after stimulation of antithrombin 3, it inhibits both factor 2 and factor 10A. So an example of synthetic heparinoids include fontaparinax, selective antithrombin 3 inhibiting factor 10A, and it is excreted by the kidney. So a patient who comes in and has a kidney problem, which drug do you give? Unfractionated heparin. So let's dig it into the unfractionated heparin. So as we said, the mode of action of unfractionated heparin, it stimulates or enhances the activities of antithrombin 3, and then antithrombin 3 later inactivates factor 2 and factor 10A. Then after the inhibition of factor 10, in this pathway I went with the inhibition of factor 10A. After the inhibition of factor 10A, then we have reduced conversion of prothrombin to thrombin, and then later we have reduced conversion from fibrinogen to fibrin. So let's just look at what I said is in terms of secondary hemostasis, we have the extrinsic pathway and then we have the intrinsic pathway. Remember the intrinsic pathway. It's monitored using which factor, which value? It's monitored using APTT. So in terms of unfractionated heparin, it inhibits both factor 10A and it also inhibits factor 2A. So when it inhibits factor 10A, then we don't have conversion from prothrombin to thrombin. And also we don't have conversion from fibrinogen to fibrin. When it inhibits factor 2, then we also don't have conversion from fibrinogen to fibrin. And if you don't have conversion from fibrinogen to fibrin, then we don't have a clot formation. So I hope you have understood the mechanism of action of unfractionated heparin. So in addition to that, we also see the clearance is through the livers, and then it has a complete antidote or a complete reversal using protamine sulfate, and then it has a shorter half-life in comparison to low molecular weight heparin. So if you have a patient who has to go to surgery, for example, tomorrow or in the next few days, then you would prefer giving unfractionated heparin in comparison to low molecular weight heparin. In terms of administration, in terms of prophylaxis, you use subcutaneous. In terms of therapeutic infusions, in terms of therapeutic, you give IV infusions. What about low molecular weight heparin? Which mode of action, which administration do we use? Subcutaneous. So how do we monitor? We monitor using APTT. So now let's focus in now on the lower molecular weight heparin, and we said before it's an anticoagulant, and the coagulants is a drug that prevent formation of clots or prevent clotting or coagulation of blood. And then low molecular weight heparin, and as I said before, the mode of action, it is what? It inhibits antithrombin. It stimulates antithrombin 3, which now inhibits factor 10A. So it binds to antithrombin 3, and after binding to antithrombin B, it stimulates antithrombin 3, not B, sorry, antithrombin 3, and then later it inhibits factor XA. In addition to that, after inhibiting factor XA, it usually decreases the conversion of prothrombin to thrombin, and later if it decreases the conversion of prothrombin to thrombin, then we will not have fibrin, the conversion of fibrin to fibrinogen to fibrin. So let's just look at this is the secondary hemostasis, which is part of the clotting process. So we usually have the extrinsic pathway and the intrinsic pathway. So we shall just go briefly in the extrinsic pathway. We shall begin with factor 12, which is converted for factor 12A. Factor 12A usually converts factor 11A to factor 11 to factor 11A, and then factor 11A converts factor 9 to factor 9A, and then factor 9A converts factor 10 to factor 10A. So our low molecular weight heparin stimulate antithrombin 3, which antithrombin 3 goes to inactivate or goes to inhibit factor 10A. So if we inhibit factor 10A, we don't have conversion of, which is involved in the conversion of prothrombin to thrombin. If we don't have the conversion from thrombin to thrombin, then we don't also have conversion of fibrinogen to fibrin. If we don't have conversion for fibrinogen and fibrin, then we don't have formation of a blood clot, and that's why they are called blood thinners. So as I said before, these are things just a repetition. They are anticoagulants, drugs that help prevent clotting. We already said their mode of action, and then examples we already mentioned, that is enoxaparin, deltaparin, nadoparin, bemiparin, cetoparin. Just to say the parins, sorry. And then the mode of action of administration of low molecular weight heparin is usually subcutaneous, and then it is usually monitored by factor XA. The reason behind this is because, just in briefly, it usually inhibits factor XA. So it is just well for us to monitor low molecular weight heparin using anti-XA or 10A. Clearance usually using RELO. That's why we see patient who comes in with clearance, creating clearance less than 30 ml per minute. We usually prefer giving them unfractionated heparin. And then antidote is usually protamine sulfate, which is partial reversal, and then it has a higher bioavailability compared to unfractionated heparin. In addition to that, it has a longer half-life, 2 to times 3 normal that of unfractionated heparin. So in terms where you have to give the patient for longer periods, then we'll prefer low molecular weight heparin. However, when the patient is, you have to give the anticoagulant, they're going to surgery like after like 2 days, then you have to convert them to unfractionated heparin because of easier monitoring and of easier antidote, that is easier reversal, which we say it has better reversal than low molecular weight heparin. So in terms of the heparin uses, just to simplify, the heparin, how we use it is just to prevent formation of clots. So anything that will predispose us to formation of clots, then that's when we use heparin. What are the contraindications of heparin? Anything that, number one, will lead us to having side effects of heparin, number one, which include bleeding. So anything that will lead us to having bleeding. Number two, anything that will lead us to having maybe in heparin-induced thrombocytopenia, or already maybe we have a reduced level of thrombocytes, and among other factors. So we're going to see. So uses in treatment of prevention of DVT. DVT is where we have formation of blood clots into the deep veins. In ischemic heart disease, this is when you have atherosclerotic plaque, which platelets play hemostasis play a role. Then we have rheumatic heart disease or atrial fibrillation. We have cerebrovascular or cerebral emboli. Remember our emboli, it's also in addition to prevention of recurrence. And then in vascular surgery, this is just for prophylaxis, and in prosthetic heart valves, hemodialysis to prevent thromboembolism. And then when you have DIC, placenta abruption in terms of malignancy, infection, and in a place where you have increased consumption of clotting factors. So contraindication about is hypersensitivity. Number two is when you have bleeding disorders such as hemophilias, where you have thrombocytopenia, as I mentioned before. One of the side effects of heparins is heparin-induced thrombocytopenia, and then where you have risk of having intracranial hemorrhage, and then where you have GI ulceration, because when you have an ulcer, you are more predisposed to bleeding. So if I give you heparin, then it's kind of I'm telling your GI, hi, I'm telling the ulcer, hi, then we can bleed because already I've given you blood thinners. And then when you have threatened abortions, then when you have renal or hepatic, advanced renal or hepatic disease. So the adverse effects we already talked about, and the first one is bleeding, the second one is heparin-induced thrombocytopenia, and we also have osteoporosis. So bleeding is the most common, and how do we stop it? We stop it by an infusion of protamine sulfate. The next one is allergy or allergy and anaphylaxis, which is heparin-induced thrombocytopenia, which is more common in which heparin and fractionated heparin. And then increased hair loss and alopecia, and long term when you use heparin greater than one, I think it's either 1 month or 3 months. I will confirm when I have a slide in terms of complications. Long term, that is osteoporosis and spontaneous fracture. So in terms of this, you consider low molecular weight heparin because it has a lower risk of us developing